Good morning, good afternoon, good evening. I still maintain your resource person. Please subscribe and so many of my video will be loaded in your phone and you will watch more of my movie. Today I'm going to talk about mental state examination. First of all, before I go into detail what mental state examination is all about, I want to tell us that everybody have his own state of mind upon how the behavior is being controlled. But with this scientific analysis of what mental state examination is all about, we're able to elucidate that mental state examination is a standardized format in which clinicians was able to record during psychiatric examination of a patient. Some people can also say they are the mental functioning of an individual upon which the individual mental state can be or mental status can be able to be outlined or described, upon which basis diagnosis can be made if the individual is manifesting with any psychiatric or psychological disturbances. Some area, however, may deserve more emphasis, like the area of mood and affect. For those people that have problem with depression, basically we talk more of their mood and their affect in details. We still have some other cognitive functioning is also area of importance because of those that have a condition called delirium and dementia. However, I'm going to tell you in details how the mental state examination is being applied. When we have what we call the general appearance and behavior of a patient, we have the speech. Some people combine speech and thought together because it is believed that whatever the mind thinks is what the mouth speaks. And it's also written in the Bible that with the abundance of the heart, the mouth speaketh. But it is based on different school of thoughts. But because we're going to give details in thought and that of speech, we'll be able to separate them into different dimensions of mental state examination. We have the aspect of mood and affect. We have the aspect of thought. We have aspect of perception. We have aspect of insight, and we have the dimension or aspect of judgment, and we still have the aspect that we call the cognition. Some people call it the higher mental state. I want to start with the general appearance of the patient and behavior. A rich deal of information can be elicited by the examination of a patient by a psychiatrist or a clinician. And in this aspect, the clinician or the person testing the patient will be able to identify the following considering the aspect of appearance and behavior of that patient. Okay, let me group this stage into two. We have the general appearance. On examination, there are areas of importance where a clinician or a scientist or a psychiatrist or a psychologist should put into consideration. One, we're talking about the patient's physique. The patient physique, I mean, is the body build of the patient. According to Canyon, we can say that patient's body build can be into three. We have those that are technic, we have those that are athletic, and we still have those that are basically aesthetic. If you are technic, we'll be able to identify or know the kind of illness or mental disorder that you can be prone to or can suspect. If you are aesthetic, we still know. If you still athletic, we still know. In the course of trying to check the appearance of the patient, the height of the patient, the weight is very, very important. Then if the patient is dirty, groomed or unkempt, which is dirty, is also of importance. If the patient is being accompanied by a police officer, it's also of area of importance. It's also if the patient is also, you know, present is being presented with blood all over the body, torn clothes, dirty, smelling, you also know where you can classify the diagnosis of that particular patient. Then let's go to the area of behavior. Yes, behavior. So we are done with the general appearance. In behavior, sometimes you check if the patient's attitude towards the examiner is, in accordance. If the patient is cooperative or the patient is not cooperative. If the patient is a patient that is attentive from what the examiner is telling him or her, is still of area of concentration. You still check about the perversity of the patient. Any irritating in behavior is also of concern. A patient appear interested or uninterested also can still put it also into consideration. Sometimes if the patient is trying to tap the feet on the floor or his feet on the floor, we call it having what we call fits or tics, or the patient is agitated, you see that the behavior of the patient is also could also be diagnosed. If patient is being very anxious or erratic in response or being grandiose in terms of when posed a question, you'll be able to know. And even if the patient also sometimes try to be, claiming to, shout on the interviewer, we still consider that area as very, very important. Then let's talk about comprehension. Is the comprehension of what is going on in thoughts. If the patient is able to comprehend, that is, understand where he is and that he's undergoing a test and he's trying to, be there. Because some people you'll be talking to some persons, their mind will be somewhere. So you try to ask the patient by repeating, can you just repeat what I said? You can also follow the patient, either use an open-ended question or a closed-ended question. Yes or no, closed-ended. Open-ended, try to pose a question that the patient will be able to, say something. From what the patient will say, we also understand the patient's mindset. The gait and posture of the patient matters a lot. If patient is staggering, if patient is walk down to the interview room or the examination room, or the patient all of a sudden, is being accompanied, as I said before, is still of area of concern. Then we'll talk about the motor activity. Is it of increase or decrease? Is the patient mood in terms of you know movement? That is the movement. Is it a movement that you must push before the patient start? What about in the aspect of mannerism? Is the patient having some manneristic behavior? All these areas should also be of concern when you are carrying out a mental state examination. Then we now go straight to social manner and verbal behavior. It's also of interested area. If patient eye contact is not appropriate, gazing around, having some status, or trying to have some vagant staring at you, you also know. Then rapport. You know, you're supposed to create a rapport at the first point, call it nurse patient or client in caregiver patient relationship, call it therapeutic relationship, where you are going to create a rapport. From there, you know if the patient is cooperative or not even cooperating. They can still, in the course of trying to know the behavior of the patient, you still watch the patient if he's responding to some hallucinatory, you know, voices, or the patient is trying to, have some feelings, that is crawling sensation in the skin, or being very, very attentive to other voices, or talking to self. From there, you also know what to do. All comes into consideration when you're trying to observe the patient's behavior. Then let's go to speech. I've said earlier that before, speech and thought is being combined when you're carrying out mental state examination. But because of this, my own perspective and area of consideration, I have to first of all talk about the speech. Yes, one in speech we talk about the rate and the quantity of speech. We still talk about the volume and tone of speech. We talk about the flow and rhythm of speech. Let's first talk about the rate and quantity. If the patient is having, if patient speech is being presented in a, let me say, like some people, the rate at which they respond to some question is selective, or you're asking the question, they refuse to talk. We say they are having mutism. You see that the rate and the quantity of speech there is being impaired. Some talk to people not in a crowd. They can be, talk to you or divide their information in the absence. So we have to respect the patient's privacy. If it is an adult that know they can speak to his, that can speak or respond all the question by him or herself, you can tell the parents or the significant other of the patient to excuse you, so that the patient will be able to, devoid most of the information. So also the presence of the patient relative can also affect the patient's openness to the interview. Then let's go straight to the appropriateness of the speech. If the speech of the patient and rate is rapid or slow, or is the speech in accordance to what you're asking the question. Remember, I'm talking about the rate and the quantity. Like now, ask you a particular question, you are flowing and you delay from what I ask you. Instead of you giving me a short answer, you give me an extra answer after answering that question, or you deviate from that answer or delay. I'll be able to know what's the problem. We'll talk more of that when we go into thoughts. So volume. Sometimes you pose a question to the person will use a very loud voice and increased tone to answer that particular question. It also check if the tone is low, if it is high, if it is normal. Very, very important. What about the flow? Is the flow smooth? Is it hesitant? Is there any poverty of speech? Is there any, circumstantiality or tangentiality that is moving round at the point answer the question or delaying, as I just mentioned before, or anything like vegetation. If there is vegetation, it is also of more of concern. Then you look into that also. Sometimes there is some therapeutic, behavior in terms of speech, where there is a stereotypic behavior, like the individual verbal issues is trying to be stereotypic as you ask, the person asks back. Sometimes you repeat what you answered before. Sometimes they try to have some what we call a collalia. He said I am. The person will say I am. From there you'll be able to understand that the patient is manifesting a particular symptom of a particular illness in psychiatry. I told you that mental illness is more of very many. We have different types of mental illness. That is why there is a call for concern for specialization in psychiatric and mental health. So, and it is very, very crucial that we should put all these things into consideration. That's why the mental state of an individual, to know how the state of the individual, the mental state is functioning, is very, very important. Then we can go into the individual is having flight of idea, individual is having clang association, like sometimes some people we have neologism also that is forming his or her own words that is not related at all. Sometimes they want to call neologism from some clan association where they can be forming a rhyme like to like John, Doin, Toin, Joyon. So that it maintain a particular rhyme, but that thing that the person is saying is not in reality. That is not in contact with reality. Let me put it like that. Then let's talk about mood and affect. Yes, as I said before, that the pervasive feeling too, which is substantive or substantial to the last for some length of time and colors to the experience of the person. So I don't want to talk more about this. The mood is just trying to tell us about the subjective feeling of an individual. Are you happy? Say yes. Are you angry? Say no. Then you pose the question to the patient, and the patient will answer the question based on what you are not seeing. So the feeling of the patient is only being seen from the affect. So the affect is of concern here now. Now we have blunt affect, like for people that have schizophrenia, you see them, you ask them question, but it's part of the negative symptom of schizophrenia. The affect will be blunt, sometimes there'll be labile, swinging of affects. There will also be incongruous or inappropriate affect. The patient's father is late, the patient is smiling and laughing, so that this patient is far from reality. Then we still talk about the thoughts. In thought, we have stream of thoughts, forms of thought, and the content of thought. In stream of thought, we talk things like the area that is very, very important in stream of thought is when you are talking about things like, for instance, trying to see the spontaneity, the productivity, the flight of idea, the positivity, because this positivity is just trying to tell you about is this speech of an individual, trying to be close to what is happening. Sometimes there also be poverty of content of speech. And see why sometimes we relate speech and thought together. When there is poverty of speech, possibly there is poverty of thought. So it can also be precious speech, it can also be precious in thought also. So block thought also can lead to block our mutism also. So the continuity of thought is assessed whether the thought process are relevant to the question and the answers so far provided. If there is loosening of association, this is from here we'll be able to define that. Tangentiality are also mentioned there. We ask person because of a person's mental state or thought problem, the person will derive from the original answer. Sometimes we see what to call circumstantiality. You ask a question to the person will now talk, and dance around, and finally come back to the answer. Let's go straight to perception. Perception is another area that must be of important. In perception, we are trying to talk about the individual patient's consideration on the five sense organs. When the sensation or what the sense organs is perceiving is not congruous to the original or to reality, you know, say that the individual is having a problem with perceptions. So we have what we call hallucination. In hallucination, we see have things like auditory hallucination, we have things like tactile hallucination, we have things like visual hallucination, we have what we call gustatory hallucination, we have a hallucination that is affecting the olfactory nerve, which is called olfactory hallucination. So this is based on the area of the limbic system or brain that is affected. There's also a type of hallucination that's also happened to a patient when he's waking up from sleep and when he's going to sleep. Some people call it a nightmare. Most of those things they call it hypnopompic and hypnagogic hallucination. They are also of more consideration in talking about hallucination. What about illusion, misinterpretation of an object or an event? Sometimes you see a snake. I mean, a rope. You say it's snake. Yeah, you can still put deja vu and Gemasview into consideration, which I have mentioned before. The deja vu and Gemasview, these are talking about you see a new thing, for instance, deja vu, you say, I've seen this before. Gemasview, this is what you have not seen. You say, you have seen that before. Deja vu, this is what you have seen, but you are trying to say that you have not seen that or you are not relating it to what you have seen before. So they are all encompassing in terms of misinterpretation or illusion. Then they want to call the personalization and derealization. The personalization and the realization are about they are all abnormalities of perception of person and reality. For instance, the realization you are very negative of what is happening, and you will never accept that this is until it happens to you. You don't know it's real. So in the personalization, some persons don't believe that this is their father. They will ask them, who is your father? He say, your father is Mr. John Ndolo. Then what is your name? I say, I'm Mr. Ndolo John, I'm Ndolo Victor. That my father is Ndolo. That this man is not my father. Really, you don't know where you are. There is problem with the personalization. Then we have what we call somatic passivity and phenomenon. Yeah, they're talking about how the somatic passivity is trying to, be related. If the sensation to the body is strange to what can be described by the patient. So, in terms of impose on the body by some external agency with the patient being in a passive recipient. It is one of the SNEDAC's first rank symptom of schizophrenia, where we put hallucination. We see sometimes we talk about this stream of thought, we talk about yeah, have in terms of thought aspect, they are going to snake that's the first rank syndrome. You see, we have where there is there will be commentary like you're now like this second person responding to the comment. Sometimes you just stand like a third person where they'll be talking about you. Sometimes also to be as if there is, the thought is being their thought withdrawal, there also be thought insertion. All these things are being applied in schizophrenic symptom that we call the first rank symptoms of schizophrenia by Snegders. But it's not the area we're trying to go. Let's go into the cognition or the higher mental state. This one is very, very important and it's very, very, it ought to be considered deeply because here I talk about the consciousness. The patient can be unconscious, the patient can be conscious, and the patient can also be in coma. When you are conscious, that is, you are aware of the environment. There is that mental awareness of self and the environment. Then, to an extent, an individual that was conscious go unconscious. Let me tell you, even though you are nursing or caring an unconscious patient, please speak positive words because the ear is the last organ to die. So always talk to the patients and do what you're supposed to do. The patient is seeing everything, is hearing everything, but it's seeing as if he's in a dreamlike state. But when the patient regain consciousness, ask the patient the question. The patient will be able to tell you that I was able to hear all the things you are saying, but that way to respond to it was my problem. So always be careful on what you tell the patient that is not conscious, that is unconscious. So the comatose patients, they are not really dead until they die. Satisfyingly died, that's when you can say somebody is dead. Then we have orientation. Orientation is trying to talk about, if the individual is fully aware of the three spheres of life: orientation to time, orientation to place, and orientation to person. So where are you? I'm in West Secondary Hospital, Mibu. That means he has passed one test in terms of orientation if he's really in Rumbo. Who am I? You're a doctor or a nurse. Yes, you have passed that particular question. Yes. Who is this? It's my mother. Yes, the person orientation is intact. Then if you ask the person, where are you? You say, I'm in the market now. Who am I? Are you not the woman that used to sell? This is the woman that used to sell okra. Is that your mother? No, God forbid. How can this woman be my mother? And who is the person talking to you now? The person that you say, you're a pastor or you are a lawyer. So, or you are those people that supply goods to people that sell something. So, you see that the person's orientation is not in accordance or intendant to what is happening. Because if you're not intendant to reality, the orientation is for total attention. There are some person that you be talking to them, the attention will never be there. Remember, this is also called the higher mental function of an individual. Very, very important. Attention is very, very what? Important. So the attention should be focused, then maintain the attention of the patient and make sure the patient give you an appropriate attention during the interview. And when there is attention, there will be the ability of what? Concentration. And when there is concentration, memory can be elicited. So If there is memory, intelligence, so through intelligence, you can be able to, bring out what you're able to, take, because there will be encoding, there will be registering, there will be storage, and there will also be, production of what I've learned or what has been spoken by the interviewer. So this is called interviewer relationship, interview relationship. So we still talk about concentration. Attention and concentration is different. I can be attentive, but I'm not concentrating. How? I can pretend to be attentive. I'll be looking at you, but I am really, being picked or having some internal itching within myself or having some running in my brain as if there is a moving sensation in my brain. I can't concentrate actually at this point. And this will also go into memory. Memory will be impaired. Remember, we talk about memory can be immediate memory. We have things like recent and we have what we call retrograde. So that is immediate, present, past. So now I'm talking to you, it is immediate. The retrograde is the thing that the memory has, for far, but not so immediately. They will talk about the aspect of um, past memory. Then you now use the term retrograde. Can be able to, retrograde. That is past memory. Now the individual will be able to. They will ask him questions that have passed for long and not be able to answer the question. So that individual is having problem with the memory part of the brain, either is neurotransmitter called the acetylcholine or the hippocampus is being affected. So those that have undergone surgery like hypocampodectomy can also have issue with this. People that have problem with short production of acetylcholine can also have issue with this. What about intelligence? Intelligence is all encompassed. I used to tell people that intelligence is just like a skill or a way of acting or being creative in a particular field. So it's all encompassing. It's not directed to only reading and writing or academic or scholastic aspect of it. Let me say academic. This is when we talk about intelligence, it can either be in terms of gifted or talented. So if you're talented, that means you can be able to do things like woodwork, constructive work, can do some technical work, can do things like repairer, mechanical work. But if it is gifted, yes, can be good with things like book-oriented intelligence. Some people are good in dancing and singing, but they may not be good in reading and writing. Some people can sing very well, but they cannot dance very well. So intelligence is all encompassing. Then what about abstract thinking? This is what differentiates adults from children. When you are an adult, you will think beyond reality. Some people call it meditation. Some people go into yoga. Some people go far. It can be because of so many things within. So some people use it as a way of problem solving skill. Some people we see things that is becoming a problem, they will go into abstract thinking in order to solve the problem. Like Elon Musk is a man that I've seen that applied the principle of abstract thinking in trying to solve the problem of the world. And he's succeeding, he's doing well with that. So I employ everyone to go into that. What about insight? Insight is the ability of an individual to understand that he is having a particular problem. So if he refuses to accept that he's having a particular problem and refuses to accept that he's in an admission, that individual is having problem with insight. So we have poor insight or lack of insight. So judgment, for instance, how do you test an individual for judgment? For judgment is the ability to differentiate, let me say, filter between what is acceptable, what is positively or generally acceptable from what is not generally acceptable. Like now, there is fire in this house, and there is phone in this house. And you know that if you go and pick up this phone, that the fire will burn you. So it is within your own willpower, your judgmental ability to go and pick up the phone and die, or you forget about the phone. Sometimes also it can be in the aspect of accident. Now you are moving with a child, and the child, you have two children going on the way. One run into a vehicle, and another vehicle is coming with a speed. You will now try to go and save the one that is already inside that vehicle, and at that particular point, you are losing the other one also, because you run into another vehicle and your own life will also be at risk. Hence, your judgment is poor. So I want to thank you. This is all I can say about the mental state examination. So check yourself and see if you have problem in any of this area. Consult or ask questions in the comment button, and make sure you subscribe. Thank you. I'm not done. Wokike. Bye.